Welcome back. This is part 2 of the abdominal injury series of lectures. We've already covered the anatomy and physiology, and I've asked you to reflect upon what is located in the abdominal cavity and where the organs are, what structures are also in there as well. We've also covered a little bit on the pain. So what we need to actually go through now is the abdominal assessment and work out what is actually causing the pain. A thorough assessment is a must, and remember to work back to one of my previous slides, the significance of actually missing a diagnosis. Some patients present with very subtle signs and symptoms, so therefore a systematic approach is essential for recognising life-threatening conditions, identifying the injuries, and for determining the priorities of care. So basically assessment is the key, and you need a really good history taking and examination to actually discover exactly what is going on with your patient. And we used the four-pronged technique of inspection, auscultation, palpation and percussion, which you may be familiar with. There are also various mnemonics which actually help you to remember how to approach the assessment and so you don't miss anything. There are a couple. One of them is called cold SPA, COLDSPA, with the C standing for the character of the pain, O stands for onset of pain, L the location of pain, D the duration of the pain, S the severity of the pain, P the pattern of the pain, and A associated factors. But what I'm going to present today is what's known as a PQRST pain assessment. So what we're looking for and asking our patient is, under the subjective data, remember subjective data is what the patient can actually tell us. So we're asking about the position. We want to know where they are feeling the pain. Which quadrant are they feeling the pain? And remembering in your mind what is located in that particular area or quadrant. What structures are there? Do they have any flank pain? Is the pain localized? We also want to know, do they have any provoking or palliating factors as well? By that I mean, is there anything that exacerbates the pain, or is there anything that relieves the pain? Is the pain relieved or exacerbated by food intake or various foods intakes? Is it relieved or exacerbated with a change of movement or position? Is the pain worse on inspiration or palpation? Do they have any history of trauma? I'm also interested in knowing, what is the quality of the pain? Can you please describe the pain? Is it dull, sharp, throbbing, cramping, burning, heavy, or is it tearing, like as in paper being torn? For these adjectives, get the patient to actually let them know what they are actually feeling, rather than giving them words, because sometimes they just agree to what you're saying at that particular stage. Radiation. Does the pain radiate anywhere? Where is the region of pain? Is it epigastric or chest? Do they have any shoulder tip pain? Ask the patient the severity of the pain using the scale of 0 to 10, with 10 being the worst pain they've ever experienced and 0 being very minimal or nil pain. Ask them about the timing of the pain. Did it come on suddenly or was it gradual? Did it happen over a few minutes, a few days, a few hours? Is the pain intermittent or is it constant? And an important thing to note too is, have they had it before? We'll also be asking the patient a lot of questions about their normal nutritional status. Have they lost a lot of weight lately, gained a lot of weight? Do they have any allergies? Have they had any alcohol intake? And medications. You will need to know what medications the patient is actually on to help you with your assessment. And we need to also include not only prescribed medications, but also over-the-counter medications and any complementary therapies they may actually be taking as well. And we need to know also, are they a cigarette smoker? And what measures have they taken to relieve the pain thus far? If they've come from home, have they had any other pain relief? Have they tried anything at home? Hot packs, cold packs, anything from a pharmaceutical preparation? If they've come by ambulance, have they had anything delivered to them, morphine or anything like that in the ambulance? So we need to know that as well. You may also need to actually look at any associated symptoms with it as well. Have they had any alteration in their bowels or urinary signs and symptoms? Have they experienced any diarrhea or constipation? Any melena or blood in their stools? Have they had any dysuria, which is difficulty passing urine? Hematuria, any frank blood noted within the urine? Or any urinary retention or having difficulty actually going to the toilet? You'll need to assess your patient as well for any diaphoresis or sweating. Or are they pale? Do they have any shortness of breath? It may be that their breathing is altered due to another cause, i.e. a chest infection or a lung process happening as well. Or it may be their pain has actually caused them to pant or purse their lips or to actually hold their breath when they're experiencing significant pain. Do they have any overt trauma that you can actually identify? Have they actually said that they've been attacked or been involved in a car accident or anything like that that may actually be causing their abdominal pain? Do they have any fever? If so, it may be indicative of an infective process. Do they have any abdominal distension? Have they noticed themselves? Remember, we're still doing subjective data. Have they noticed they've had any swelling or feel bloated? Have they had any back pain? Have they experienced any anorexia or nausea or vomiting? If they have vomited, then you need to know more about the vomit as well, what was actually contained within that vomit. You also need to ask them about any other past history, any previous GIT problems such as gallbladder or irritable bowel syndromes. Have they had any previous surgeries such as appendectomies, colostomies? Their urinary habits, as we've mentioned before, do they have any frequency, nocturia, any major illnesses, any hepatitis risks, their vaccination status, any family history problems of kidney issues, colon cancers, malabsorption syndromes, gallbladder diseases or colitis. Your assessment at times can seem to be reasonably overwhelming because you've got to ask so many different questions and everything else. Then we move on to the objective data collection. So this is where you actually undertake the inspection first. So stand at the end of the bed and inspect the abdomen for the contour and the shape, symmetry, any pulsations you can actually note as well. Determine the profile from the rib margin to the pelvic bone, and in your mind visualize exactly what's underneath there. Look for things like scars or sinuses, any fistulas, any visible peristaltic movements, any descended veins, any flank hemorrhages or ecchymosis, which is bruisings, prior to moving on to osculating for any bowel sounds. And bowel sounds which are hyperactive, which may be loud and indicate an early bowel obstruction or gastroenteritis or laxative use or diarrhea. Hyperactive bowel sounds are generally softer than normal and less often, usually around about every 1 to 2 minutes, but they're usually heard. You may have to stand there for quite some time before you can actually hear it. Or absent bowel sounds may be indicative of post-op complications, paralytic ileus, peritonitis or late bowel obstruction as well. And osculate the chest too. I know we're looking at the abdo area, but osculate the chest, and if bowel sounds are heard in the chest area, it's usually a bit of an indication of a diaphragmatic rupture with a herniation of the stomach or small bowel, into the thoracic cavity, which again would be another surgical abdomen, and obviously you'd be referring on. In regards to still looking at your patient with inspection, there's various specific abdominal signs that you may be looking for which indicate varying degrees of abdominal trauma or other areas. So listed up here for you are the Murphy sign, which the patient has an inability to actually inspire deeply due to pain on palpation of the epichondriac region. There's a Kerr's sign, which is a shoulder tip pain, which usually indicates a ruptured spleen, ectopic pregnancy, or may not be associated with appendicitis as well. And then you have various ones which are associated with different flank pains, scrotum pains, umbilical pains, where you have ecchymosis or bruising of those particular areas. And there's just examples of those specific abdominal signs that we've actually gone through and what you'll be looking for and the location of those different bruises and ecchymosis. There's various investigations and management associated with abdominal pain. Symptom relief should be given before examination if necessary, and there's strong evidence that analgesic does not actually mask the physical signs, and if the patient is overtly affected by pain, then the assessment modalities cannot actually be undertaken in some cases unless they've actually had some pain relief. Normally though, we do keep our patients nil olari until after we've had a review and we've actually got a firm diagnosis, just in case they will be heading towards theatre. So we can actually give some IV pain relief or oral pain relief if it's actually indicated and surgery's not. We normally do a 12-lead ECG just to exclude any acute coronary events. We normally have our patients on pulse oximetry as well, and titrate O2 treatment requirements to whatever's necessary. We normally take general bloods, such as a beta HCG on any female that basically comes through between the ages of around about 10 to about 60. FBEs, ESRs, UNEs, amylase, CRPs and LFTs, which you're looking at your liver function tests, you're looking at any indications for fevers or anything else. What we're looking here for is to see what the patients actually come in with, so we've actually got some baseline data of which to note any deterioration or improvement. Normally do a random blood glucose, and we've normally got an IV in, so we can actually give them some IV fluids as indicated and to take our bloods. We normally do a urinalysis to rule out UTIs, which is a common presentation for both children presenting with abdominal pain and for the elderly. Abdominal X-ray is of limited value, but it's first line for bowel obstructions, perforations and things like that as well. And abdo ultrasound is rapid, non-invasive and can actually be done at the bedside 9 times out of 10. Abdo CT is the imaging modality of choice in the non-obstetric patient. There's usually a high degree of accuracy, 95% in one of the studies we can actually refer you to, but the patient actually must be stable to be able to go. And the fluids will be directed by the patient's findings, what you found on their vital signs, how they're presented and how they're responding to any interventions you may have already put in place. Antibiotics may or may not be necessary, and it depends if there's an intra-abdominal septus, then we may actually need some antibiotics. And a PR and PV examination is usually on a PRN basis. And a surgical consult, it's a good idea to get one early to rule out any theatre. So now we'll take another short break and I'll come back and we'll go over abdominal trauma, part 3 and the case study. And